Can I just ask members of the public to make sure their videos are off, please? But welcome everyone, nice to see you all. Well, welcome everyone, and welcome to this, the August meeting of the George Eliot board. We had a very fruitful workshop this morning where we were presented again with the fantastic progress on our accident and emergency and critical care department, and Naj and the leadership team there and everyone involved at the front line doing an absolutely superb job for the citizens that we serve. Then had a discussion on our responsibilities as an anchor organisation, and then reviewed some of the, again, fantastic work which is going on digital innovation using the digital hub facilities and our relationship with SSC. But again, some of our consultant colleagues at George Eliot having a really impactful series of pieces of work which over time I'm sure will have a significant impact on our patients and those we care for. So quite a lot of ground to cover. So we have apologies from Gertie, Jenny and Simon today. Any new declarations of interest that we should be aware of? Okie dokie, so we'll move on then to the last set of minutes, the minutes held of the 6th of July. Was everyone happy with the accuracy of those minutes? Please raise a digital hand if you want any adjustments. Okay, so we move on to matters arising then, if we can. The first was for HAC to produce and share with myself and Glenn a Jacob's ladder based on agencies' usage. HAC, you circulated that to Glenn and I, thank you. Will be really great over time if as far as possible we can do an apples with apples comparison with colleagues in the foundation group. Appreciate there's some challenges there. The next was for Stephen to bring back a report on work being done with UHCW to address delays in shared service referrals. Stephen, where are we with that, please?
Yeah, I've sent a note through to Nhs. I'm suggesting that we'll bring the report back for October board. That should give us August, September when most people are back and we can evaluate the work and then produce a report back to October board at the beginning, if that's agreeable. Okay,
that's fine. Thank you, Stephen. Then on the medical education team to be invited to a future board workshop. Catherine?
I think that Gertie reminded us afterwards that we'd brought the education strategy to the board workshop earlier in the year, and therefore there was a proposal that would be duplication, but be completely guided by you as to whether or not we should remove it or leave it as it was.
No, I'm happy with that. Thank you, Catherine. And then it says Stephen, but it's got David's name next to it, be invited to deliver the SDMP at the Health and Wellbeing Partnership Board. That's been added to the next agenda, I understand. So thank you for that, David. Then Jenny to ensure that future improvement reports capture the patient's experience. That's been done, so we look forward to seeing that going forward. Then we have the referral on the FTSUG. I always hate acronyms. I'm trying to remember what this one is.
Freedom to Speak Up, Russell.
Thank you very much. Guardian. The Freedom to Speak Up Guardian to ensure the nursing and midwifery category in figure 3 of the report be split into separate categories. And Sue is going to do that, so that's deferred until September. Thank you. Then HAC, bless him, has to come back with the half-2 plan. We are driving through fog at the moment when it comes to the finances, HAC, so you have our sympathy, but that's on the confidential agenda. And then on the new improvements report, that to be presented to the board from August 2021, and that's on the agenda, so come back to that in due course. Are there any matters arising that I've missed? Okie dokie. So Glenn, I think we're over to you.
Thank you, Russell. So I'll start with the most important item in my report, actually, which is the issue of discriminatory behaviour towards NHS staff. I took the opportunity because the issue of racism was in the media linked to our footballers, to kind of remind the community that we serve that this is something that our staff often face every day, and we felt it was appropriate to speak out about it, and really positive in the way that it's been picked up by local media and social media, and our staff have also been very grateful that we have called this out. And obviously I explain within the report that our staff are incredibly professional and they understand the occasional confusion of individual patients, and will always treat people in an emergency situation. But patients who decline treatment from one of our BAME staff are declining treatment from us. And that's something that I'm really clear that we should take a stance on. So I think the other thing that encouraging our workforce to do is that the victims of this can feel incredibly stressed. So I'm encouraging our general workforce to stand out. There's nothing like colleagues calling this out, particularly non-BAME colleagues calling this out and dealing with it. So we'll be doing quite a bit on this as an organisation. We'll be encouraging our staff to report incidents and supporting them and how to deal with them effectively. And I hope this is something that we can really take a stand on. There's also a creeping issue of violence and aggression towards staff in other ways as well, and we talked about that a little bit when we talked about our emergency department earlier. Again, it's totally unacceptable, so we will be dealing with that also. My report then goes on to talk about the revised isolation rules for frontline staff, which are welcome, although I think it's well worth caveating that at the moment the rules are that if there are household contacts, our individual staff members still have to self-isolate. So we still have quite a few staff that are affected by this, which is adding to our pressures alongside, and we'll talk about later in the meeting, the increasing urgent care pressure, the really impressive recovery stats on elective care and cancer recovery. So these are challenging times for the NHS. Busiest July I can remember has just ended, and I've got an awful feeling it might be the busiest August ahead. So we'll keep focused. And linked to that, whilst there's been a relaxation of national restrictions, we're still very focused on infection prevention and control in the trust. We will be wearing masks. We will be asking visitors and patients to. And again, there's been a little bit of challenge back sometimes from patients on that, but we will be taking every precaution we can to ensure that patients and staff are safe. I then give an update on the IT transfer, an update also on the work we're doing across the group to improve information, including the standardisation of reporting through to all three boards. That will also help us to do more comparative work as we move forward with some of our work across the group. And then an important piece, an update on our finance and procurement team. So we've talked quite a lot about some of our frontline teams, but very much on the front line during COVID were teams like our procurement teams and our finance team keeping the service going. I think it's fair to say there's been quite a complicated set of circumstances around the way we've managed our finances over the past few months to make sure that we are effectively recharged for the things that have gone on. So well done to Hack and his team for the way that they've professionally managed that over that period. And then also an update from the Clinical Support Services Division, including successful recruitment of 8 anaesthetists to fill junior posts. So that's good news. Happy to take questions, Chairman.
Thank you very much, Glenn. And just before I invite questions or perspectives, I just want to reinforce the point Glenn made in terms of our total abhorrence and zero tolerance of racism. We are proud to be an anchor institution in our community. We're proud to serve all members of our community. I'm immensely proud of the diversity of all of our colleagues. We as an employer are only interested in your character and your competence. Everything else, sexual orientation, any disabilities, background, any sort of challenges you face in life, if you have the right competence and character, we welcome you with open arms, and we will not tolerate any racism towards our staff. We are particularly aware of the racism that some of our staff face on the night shifts. So just on behalf of the board, I'd particularly like to thank our colleagues who work the night shift and have to put up with abuse from patients who frankly should know better. So I just want to reinforce that on behalf of all members of the board. So questions and perspectives to Glenn? Julie?
Thanks very much, Chair. And thanks, absolutely endorse what you've just said, Russell and Glenn. A really good report, Glenn. There's just one query, which was around the self-isolation rules, where we talk about clinic being allowed to support clinically vulnerable people. That was a very wide definition at the outset. I wonder if that had changed in this particular category.
It hasn't particularly been defined, but what it encourages us to do is to carry out risk assessments in all cases. So whilst the relaxation of the rules has been helpful in a way, it hasn't led to lots of staff being able to return to work, because obviously a lot of what we do is managing individual patients where they could be clinically vulnerable or they are clinically vulnerable. So we're being very cautious about the way that we allow staff to return, and I suppose that's the other point I'd make. This is staff wanting to return. We're not forcing them to return under these rules. So it's made a difference, but not a huge difference yet.
Thanks, Glenn.
Thank you, Julie. Any other questions to Glenn? Otherwise, we'll move on to the improvement programme. I'll just say to members of the public, as Glenn said, it is an incredibly busy time for the NHS at the moment. And made more challenged by the so-called pingdemic and the other aspects of COVID, which are causing challenges to all of our frontline teams. So, but we are open, we are here for you, and we're here to serve. Glenn, the improvement programme report, please.
Yeah, this would normally be for Jenny to report back on, but she's not with us today. And I took the opportunity to feed this one back because one of the most enjoyable meetings I chair is the improvement board, where we bring together the improvement programs across the organisation. We have a similar board at Swift and at Wye Valley, and it provides a great opportunity for us to share best practice. So Ali Bolton is the improvement lead across the group. She attends all of those meetings. She's been coordinating the training of staff in the QSO methodology, which as a board we had a bit of a go at one of our 3 board sessions last year. That's moved into a virtual format, but has kept going during COVID. And what you see in the report is a really good overview of the programs that are underway, the training to staff to support that, and the amount of change and improvement that's going on across the organisation. I think one of the other things I'd emphasise as well is we've changed the focus to be more place focused rather than just the hospital itself. And you'll see that in some of the programs that we're doing. And indeed, this morning, when we had feedback from the A&E team, that is a fine example of lots of improvement work that has been led by the teams that are empowered to make changes. And our approach is very much to encourage people, be permissive about change. Sometimes it doesn't work, but you learn more from the things that don't work so well than the things that do first time. I'm happy to take questions on the report, but it's a well set out report from Jenny.
Thank you very much, Glenn, and like you say, a really great programme of work. Any questions to Glenn on the improvement report? I think it is one of the areas we've made great progress over the last few years, is on getting a whole bundle of innovations coming up from our frontline teams and moving forward at the direction of Ali. It's been a really good programme. Glynis?
Thank you, Chair. I mean, it is a really good report. It's very encouraging that there's a big focus on continuous improvement, but particularly that we're equipping our staff in it. So it was just really about the numbers of staff going through the CUSA programme. I mean, it was great to see, even though they've got a pandemic and the pressures, we've had 42 people going through. I just wondered if we'd got some sort of plan or some sense of capacity and how we are prioritising staff to go through the programme.
Yeah, it's a good question, and we are. I mean, we're not forcing staff through it. We're taking lots of staff, and there's actually a bit of a queue of people wanting to do the training. One of the things actually we discussed at the last meeting was creating improvement apprenticeships that will firstly we'll be able to access the apprenticeship levy, but we'll also then create some people with some more time to support the improvement products. So we haven't got a specific target number of staff, but what we're trying to do, and apologies if you can hear an alarm going on in the background, what we'll be trying to do is make sure we've got enough people who have got the gold level training, which is the full skill set that form a kind of reference group within the organisation, and then encourage as many people as possible to do the virtual training. We also promote it as part of induction, that is our technique that we approach. And these apprenticeships will be the next things that we'll get going very, very soon.
Thank you, Glynis. And Rebecca.
Thanks, Russell. Glenn, really interested to find a little bit more about how our place partners and their expertise is being utilised in our improvement programme. It's really heartening to see this being headlined consistently now. Thank you.
Yeah, the approach that we've decided to take is that the training that we offer, we will make it available to our place partners for free. So it's something that we've created across the group, and we've got the same approach throughout the group. So particularly primary care and social care colleagues taking part in those sessions. As I've just said, we've obviously got internal demand to access these courses as well, but I think it really adds value if we can add other people from the system, particularly as we start to look at pathway improvement and just get the expertise of other people within the system. So so it's open to particularly primary care, but also social care colleagues, and that's gone down very well with partners.
Thank you.
I think the other thing, Glenn, just to add to that, is I'm absolutely sure there are certain things the NHS can learn from local authority partners in particular, given the value for money challenges they've had for the last decade. Colleagues, happy to move on? Great, thank you. So we're then on to the winter plan and resilience. Stephen?
Yeah, thanks. So it kind of really segues from the improvement board, because one of the things that you'll see in the structure around the improvement board is the work streams that we've been running for quite a while now. So I think one of the things we've successfully done is move out of a kind of stop-start planning cycle around winter and bed capacity and how we cope with the pressures. So actually it's more of a continual process now, and that's managed through the unscheduled work stream that we run in the coordination cell help with, and Craig Simpson, who you met this morning, who's the GM for medicine, is the lead for that. So this really is just a bit of a stock take for now on kind of our approach, where we're at, some of the headline schemes that we're looking at. And the plan is, and it's on one of the slides, is that we will then we're widening it out with the community, with place partners and the mental health trust, to then bring in what the social care schemes will be, what the community schemes will be. And I think like previous years, we'll probably bring it back to board around September, October, probably more October. So board get to see a holistic picture of how we're kind of tackling those pressures. Just a couple of bits I want to draw out just from the slide deck is we've kind of given a broad aim this time, and we've tried to do it on a bit of a 360. So we cover A&E, we cover our occupancy, but we're also including discharge planning and admission avoidance as key strands that we're looking at through this. And we've also set a set of objectives that we want to try and hit through the winter planning and be able post it to look back and say, was it successful or not? I think too many times in the past, hospitals and systems have done it in a way of, almost did we survive winter, what do we at. We've tried to set a really clear set of objectives that we'll go through and do a post-evaluation review of following it. And then we've listed some of the schemes, and these are the ones that are kind of just are being worked through, and there's some really important ones in. I'm going to pull out two just to highlight more for their approach rather than their particular relevance. One is the alcohol and substance liaison nurse, and there's two of those, and we approved that business case at TMB, and that really is an improvement journey that kind of has come to life and had a real benefit for us. So I remember when I started with the trust a couple of years ago, there was a real signal from GIRF that we needed to improve, particularly around the gastro wards. They were keen to do it, and we knew that we had a high number of people presenting at A&E that had alcohol symptoms or alcohol problems and were attending through A&E and then ending up having subsequent admission. So we did a partnership piece of work with CWPT together to look at bolstering that service, and we piloted it with one nurse who has presented at the A&E board, and we fed that through to place and into system as a really good piece of work. And now the teams have taken that on and looked to bolster it, so we're in the process of doing that. I think the bits of one is we're being driven by the evidence, so we were driven by GIRF to have a really good look at it, and that there was some evidence around that of what we can expect. But I think the other bit that I wanted to draw out was this was real evidence for us of the team stepping into a space where it would have been easy to probably look to somebody else to do it and mourn about how it hadn't been happening, but actually they stepped in, they proactively worked with CWPT, we came up with a solution, and we're taking that forward. And the other one I really want to draw attention to is the respiratory support unit. So this is real learning from COVID and planning, and we're getting that through the national guidance around that. So the team there have worked really hard on what that would look like. We've brought a lot of capital equipment in, and the bit we're now looking, and we're tying that into the accelerator scheme as well as around the staff and resource. And really that's more around specialist nurses. So we're looking to bolster that, and that'll be in place. That'll have an ultimate aim of making sure that ITU can cope throughout, but also it will have an important impact on our elective work and making sure that we can do both as we go through winter, which certainly I can speak for the last two winters, last two pre-COVID winters, is something that we'd struggled with. And then, so as I said, we've set some outcomes, and then I've just highlighted the next steps. So really the bits that board will be interested in, they'll be much wider. It's driven through the A&E board, and then we link it to place. And then really what we then do is get into weekly tracking of it to make sure that the programmes that we decide on, we have a high focus on delivery. Happy to take any questions.
Thank you, Stephen. Questions or perspectives, Glenn?
Yeah, thank you, Stephen, and some good work there. I know one of the things that will frame this is the work that you've done recently on point prevalence study. It's not referenced here, but that opportunity to left shift where we kind of look at whole system capacity. Are there any headlines from that the board ought to be aware of?
So I think what we've picked up from that is really the work that we're going to do with the community and the local authority around our packages, particularly packages of care. I think we're really good at using them. I think the left shift we need to make and work with them is there's a slight danger we overprescribe. So we'll look for 4 times a day calls when actually 3 or 2, and of course that releases capacity further down the line. So I think generally we've shifted it in the right way. One real strength that we want to keep looking at is the discharge to assess pathway as well for bedded, because we seem to do well at that. If you look at how many beds we have available to us, we actually really use them well. So we're going to look to strengthen that. And I guess the other bit in there is the virtual ward is the other big shift for us. That's the one that can start to become a bit of a game changer over the next 2 years.
But sorry, just for members of the public, a point prevalence study is a point in time where we analyse where patients are and where arguably they should be for the most sensible healthcare setting. And then you see how the cost of where they are now with where they should be compares. So that's what the point prevalence study does. What was the saving, Stephen, though, when it was recently done in terms of for our community if we had people in the right setting?
That's a good question.
I think it was about 5 million, wasn't it?
Yeah, that's the figure.
So again, just so people are aware, so if people in the right healthcare setting, the system, not us, but the system would save 5 million. So it's a prize really worth going in terms of ensuring people in the right setting. Lots of questions, so if colleagues can ask their questions succinctly, that would be great. Catherine, you're next up.
Thanks. Well, we're certainly having a very busy summer, so we can anticipate an even busier winter. It's really helpful, Stephen, to see those all together. How are we, and many of those ideas have come from the staff themselves, how are we having that conversation with the staff in order to make sure that they're aware of the breadth of that and continue to add their brilliant ideas to help us get through this winter as best we can?
So I can tell you none of the ideas have come from the managers, they've all come from the staff.
That's great.
In the unscheduled work. So there's a big piece, to give you an example, there's a big piece of work that the medical teams, gastro, frailty, are all undertaking around looking at the bed modelling. And they're coming up with the bed model solution that they think. So that could be a potentially big piece of work. But I can say we haven't come up with any of these. This is not a top-down approach.
Great is if we started to celebrate the staff who are coming up with the great ideas.
Yeah.
Every idea is a good idea, but some ideas are more implementable.
Yes,
so let's start to celebrate, that bed blocking thing. Who came up with the idea? Let's celebrate them. Thanks, Catherine. Rebecca?
Thanks, Russell. Really strong report, Stephen. Develops a lot of confidence. Education of the public and patient voice is also key. Where will that be in this plan, please?
So actually, one of the things we've been doing, and we're picking up at place really with Healthwatch and in the system A&E board, is alongside the point prevalence, we had an audit done that was called Missed Opportunities. So that was an audit of one day in A&E and looking at where people, should they have accessed A&E, what was the alternatives in the community or primary care or third sector even. And also when they came in, did they go to the right place? So you'll see that in there with Esther, but that's a piece of work that we're picking up with Healthwatch. The bit I would probably put in there is you can spend an awful lot of amount of time, and it will be a definite long burn to try and educate the public not to attend A&E if that's their default, but that's the piece of work that we're doing. And one of the schemes we've got is a high intensity user, and that's user manager who's actually working with the top 20 people that attend A&E on a very frequent basis. So that is kind of real user involvement, because what she's developing with them is a care plan around when they're starting to feel they need to come to A&E, what's the alternatives that we can put in place. And there's a lot of work with the third sector on that. So we're using it on an individual and a kind of more organisational view with Healthwatch.
Yeah. Thank you.
I think just building on Rebecca's point, we haven't, I don't think, recently had our colleagues and friends from the press at a board meeting with us, but maybe a series of articles by Catherine and Dowd and maybe you, Stephen, on how to look after yourself in the winter. Working with our local press colleagues would be something worth thinking about. And Glynis?
Thank you, Chair. A couple of just quick queries, Stephen, if you don't mind. It's a really helpful presentation. I really liked it. It covered all the key points. Performance and expected outcomes, high level ones, we own them. It's just how we're making sure that all our partners feel that the schemes they're delivering contribute to them, recognise them and work towards the same common high level expected outcomes. It's the first question. And the second one, just a quick query about a number of staff that you're taking on as part of these schemes. Are these substantive or temporary posts? Because I know sometimes the challenge with temporary posts in recruiting and attracting staff is a challenge.
Yes, if I deal with the outcomes piece first. So we've heavily driven it through the local A&E delivery board. And there are various streams of work going on, particularly with the local authority. So they're kind of aligned through that way, and we've used a common language through. So that's how we've tried to do that one. And we've also taken that through the A&E delivery board. So at a senior level, we're getting senior buy-in to make sure that those messages are driven through the organisations as well. And I sit on place as the chair of A&E delivery board, so I talk it through kind of every 2 months there as well, so take that through. So I think we are aligned, and the other bit we do is use a common currency of measurement. So we'll use our current average length of stay mechanisms that we do, and that's really the best, simplest one-off measure that everybody gets to see, is it working or not. That's the one that we can use there. In terms of staffing, so some of them will be just remodelling what we've already got. I think some schemes will be recruitment, and I think some of that is how we sell that. So we had great success with the Captain Tom Moore unit in the theatres because it looks something different, and the medicine team in particular have taken that on. If you advertise general medicine, you're probably less likely to get, if it's packaged as this is a whole pathway change and it's frailty or it's something else, we're more likely to get success. The other thing we have done, working with primary care and the CWPT, is look at working across organisations as well. So we've seconded staff across both or done joint posts. So in our discharge team, we've got people working who work across both community and the acute, and that looks quite attractive if you want a portfolio career. You don't just want to work for one organisation, or you want a different experience, and we've done that with a couple of ACPs as well. So there's not one golden bullet, it's just a number of things that we're looking to kind of tackle and make it look attractive to people.
Thank you, Stephen. Thank you, Glenys. Okay, colleagues, we'll move on now. We're running a little bit behind time, so if we can try and pick up the pace. The Welcher North Place update, written by Jenny, but David, key points to pick out, please.
Yeah, thanks. I mean, first of all, I think just to make the connection between the two items we've just covered relating to the improvement board and the winter plan and the approach to all of that, there's a sort of golden thread that runs through into this item with Warwickshire North Place as well. Second thing I wanted to say, I think it's great to see this report being prepared by Sophie Hinsley, who's one of our graduate management trainees, and not only have we got the report, but also you can see here the commitment to us educating our managers to prepare for more senior roles in the future through getting involved with things like this. So this was great to see. So the board's previously seen this update, which covers the high-level overview of the 6 themes, which are the focus of Place's work. I won't go into any detail, and I know that people will have read the report, but I guess just 2 things to pull out, really. First of all, it's good to see some thinking starting to happen around enablers, and we spent some time in the board workshop this morning hearing from Andy Labrick about the digital agenda, and that connects very strongly into that enabling piece, which is beginning to become much more a focus of Place conversation. Also, data and insights and the production of a dashboard connects very strongly to the cues and methodologies, particularly around measure to improve, understanding what's happening in an area or a programme of work through being able to access good data, interpret that, create a plan about what needs to happen, and then using the measurements to determine whether improvement is taking place. I think that's quite an important thing to draw out of this report. And then finally, just to connect it to the opportunities that exist across Warwickshire North, and indeed probably across the Coventry and Warwickshire footprint more genuinely around estates opportunities and the opportunity to work with other partners to use estates belonging to different organisations in a different way, which also connects to the sustainability and environmental agenda that we talked about at last month's board meeting. And so that estates discussion and the conversation that's going to take place around that becomes more and more important for us as we start to kind of unpack some of that. And just building on that, and one final point, Stephen and I promised that we'd meet with Councillor Condacor to explore some of his thinking and ideas. I don't know whether he's in the audience today, but just to say that meeting is taking place tomorrow afternoon, and all sort of bundles into that whole set of place, community, wider determinants of health conversation. So I'll stop there and take any questions that people might have.
Thank you, David. Any questions or perspectives to David? Julie?
Thanks, David. It's a really good report. It's good to see what's happening. My concern is a little bit around, we're showing these programmes as discrete programmes, and I'm just interested to understand how they are managed in relation to each other. So something like how homeless support impacts on community mental health, or mental health with dementia. that's the first thing, and also how it links to our next item on the agenda. So how are we taking account of the diagnostic hub, for example? That's my first question. Second one is around, it's a big report, and how are we ensuring the visibility of the reporting of this through to ICS?
So let's start with the question there about the way the programmes interface with each other. I think Salma has joined the audience. So Salma coordinates a piece of work through a delivery group that brings all of the things that you see reported in here together. They in turn then report into the place executive, and there's really good, strong coordination of the people who are responsible for leading each of these projects that sit in this set of themes. So I'm not concerned at all that there's people duplicating and repeating. It is very, very well coordinated, and there's lots of communication on a very regular basis around this, which comes together in the delivery group, which Salma and colleagues are involved with. So your second question was around
how to bring that up to the ICS.
Yes, so connectivity into the ICS. So this report is sent, it's not just prepared for our trust board, we also submitted to, or our partners submitted into various governance arrangements that exist within their specific organisations. That's the first thing to say. So it doesn't just come to our trust board, it also comes to other governing bodies and the various different provider and commissioning organisations that sit around the place. Once a quarter, I go to the PEG meeting to present an update on behalf of the Warwickshire North Place Executive, and we use this report as the basis for that briefing into PEG. And we are also making sure that this information is available to the Health and Wellbeing Partnership Board, which is the Warwickshire North Health and Wellbeing Partnership Board, but also there is a Warwickshire Health and Wellbeing Executive, which is chaired by Nigel Minns, and information from this report also goes in there. So that gets directly up to the Coventry and Warwickshire Health and Wellbeing Partnership Board. So both of those routes into the kind of senior governance arrangements across the system are covered off. And then your third question was about the Diagnostic Hub, I think. And Catherine is a member of the Warwickshire North Place Exec, has led and chaired the development of the Community Diagnostic Hub across the system. And we'll talk to that in some detail next. But again, very confident that partners across Warwickshire North have been very closely involved in the development of the business case that we're about to hear about. And the test, Julie, is when you go back into Warwickshire North and talk to partners, and they are able to reference some of this stuff and to have a conversation about it. They do that, they're very familiar with it, and it's become a bit of a common language across the piece, which tells me that people are engaged with it and that it's working.
Okay, thanks. We're now running quite late, guys. Glynis?
Just a quick question and probably an observation, David. It's great seeing all these schemes, but it's important that we get some sense of progress in terms of impact and evaluation. But it has struck me, looking at the schemes, that a lot of them also tie into the high-level objectives and outcomes that Stephen's just talked about in terms of the winter plans. So I'm asking, how are we making sure that they all link together in terms of outcomes?
Yeah, okay.
Yeah, we need to make sure that happens. Just very quickly for me, the thing which I think this is a great report, it's really encouraging to see the benefits realisation and the broad framework of projects that are going on. I would like, though, an overarching narrative, and we've talked about this before, better outcomes. The reason we're focusing on place is to achieve two things: better outcomes for our citizens, better value for the system. Otherwise, there's no point. And that is the whole point of focusing at place. We believe we can deliver better outcomes for our citizens at better value for the system. So can we try and ensure that almost every time we have reports like this, we have a subtitle, better outcomes at better value? Because otherwise we're in danger with, as things develop, losing sight of the big prize. And the big prize is delivering better outcomes at better value. Now, on the subject of better outcomes at better value, we're now moving on to the community Diagnostic Hub business case. So Catherine, over to you.
Okay, well, indulge me on this one, and I promise I'll make up the time on my next 5 reports. So the Richards Review was published in October 2020 and was really addressing the fact that there's a problem with diagnostics, that there is an increasing demand for diagnostics. Nationally, things like CT scans are expected to increase by 6.8% a year. So that's a big increase over a 5-year period. And also many organisations have built up a backlog of diagnostic testings because of the COVID pandemic. And there was an importance to try and separate acute diagnostics from planned diagnostics. So the Richards Review set out a number of aims, that there should be acute and elective diagnostics should be separated as far as possible to increase efficiency, that acute diagnostics for ED and inpatients needed to be improved so that patients were not waiting in hospital for tests, that community diagnostic hubs should be established that should be separate from acute sites, or if they were on acute sites should be separate buildings so that you didn't have mixing of COVID and non-COVID patients, and that diagnostic services should be organised in such a way that you could be tested for COVID beforehand if that was required. So the paper that is in front of you now is the response from Warwickshire North around the plans for a community diagnostic hub locally. The plan is that for about 1 million population, there should be approximately 3 community diagnostic hubs, so about 165 nationally. This would be our community diagnostic hub serving the population of Nuneaton and Bedworth and North Warwickshire. The first phase of the building is what's presented for you here, which is a £3.6 million build. We have put in a bid nationally, and it's indicated that we will receive £2.75 million for that. So we're asking for a further £0.85 million from reallocation of our capital programme. This has been through a lot of governance, both internally and within the system. So within the system, this has been discussed at the Community Diagnostic Hub group, the Diagnostics Board, the Provider Collaborative, and the Partnership Executive Group. It's also been through the Trust Management Board internally, who have looked at the capital programme reallocation to support this and approved that. It's really great news for the local population, meaning that we will be able to provide state-of-the-art diagnostics for our population without having to travel further afield. One of the things that the community diagnostic hubs are trying to do is address inequality. And we know that for many of our population, lack of car ownership or difficulty with public transport means they can't travel a long distance for tests. And this will help improve things like cancer diagnosis. So the first phase of the building, the enabling works, the demolition starts tomorrow on site to build it. And it will provide plain film, x-rays, lung function tests, heart scans and ultrasound. There will be a second half of that building to bring our cancer diagnostics together and do CT scanning there and access to MRI. That's subject to another bid that is going in at the moment that we're all frantically working on. But this is the paper in front of you today. So.
Thank you, Catherine. Just before we open things up, so just to confirm, who in the system has basically signed off this business case? We're now having to work on a business case perspective. So there's a Community Diagnostics Hub team that signed it off, is that correct?
Yes, that answers into a diagnostics board. So we have diagnostic experts from around the system who've looked at this bid and signed it off. It then goes to the Provider Collaborative, which Glenn chairs, which brings together our providers across the system, and then to the Partnership Executive Group, which is the accountable officers. It's also been to the Finance Advisory Board. I should have mentioned that. So our directors of hack smiling, the directors of finance have crawled all over it as well. So I don't know if there's anybody who works in our system who hasn't seen this bid.
Yeah, no, I'm just making sure who signed it off rather than seen it. So Peg has signed it off, Glenn?
Those groups that I've mentioned and the Partnership Executive Group.
Okay, thank you. So questions and perspectives, and thanks, Catherine, for your hard work on this. This is an incredibly important development for the citizens that we serve. Glenn?
Yeah, I was going to thank Catherine because obviously she did this work on behalf of the system, and as she said, it came through to the provider collaborative that I'd chair on behalf of the system, and then we signed it off and it went up to the partnership executive group. So it's a really good set of proposals. I mean, we are incredibly fortunate in Coventry and Warwickshire that we've got one of the best equipped modern hospitals in our system, but it is in the centre of Coventry, and I think part of the strategy around the community diagnostic hubs is about making sure we have access to capacity locally. So another part of the bid is to do something in the South Warwickshire system with the Stratford Hospital. So this is so important for the population that we serve. There are, as I said at the last board meeting, more older people living in poverty in Warwickshire than there are in Coventry. And so access to transport is a really important issue. So our decision to place this capacity and prioritise the investment at George Eliot, and George Eliot has been rather starved of capital, I think it's fair to say, over the last decade or so. So it's good to see some investment going into Warwickshire North. So I'm very supportive of this.
Thank you, Glenn. And just before I invite Rebecca to ask a question, Hack, in terms of the 850,000 reallocation of capital, you're fully supportive?
Yes, so I'm in the capital paper that I presented to the board last month, we allocated, rejigged the capital programme, we allocated the appropriate funding as Catherine set out.
Yeah, so yes, thank you. So questions and perspectives, Rebecca?
Thanks, Russell. It's the right thing to do as a local citizen living as part of the community. It's time we rebalance care at place. For local people, and particularly for those people in North Warwickshire living in Dordon, Upper Arley, as well as people in Nuneaton and Bedworth. So absolutely supportive of this. Thank you. Okay,
thank you, Rebecca. And Stephen?
Yeah, just wanted to kind of emphasise, I think, Glenn's point of the population and the way that we describe things like concepts like deprivation. I think you can measure that in a number of ways, and you can do absolute number, or you can look at multifactorial, and poverty is one of them, and distance and access to things. I think the other bit is, although this is a community diagnostic hub, I remember early days in the place discussion when we first started talking about it, about citing it at George Eliot, and there was a really clear steer from partners that this was in the community and they felt that. So a lot of the narrative nationally was around almost staying away from acute, whereas we got that buy-in very early from partners and, again, Health Watch and the public, that they saw George Eliot as the community. So I think that's an important point to draw out.
Thank you, Stephen. So if you're not happy to support this, could you please raise a digital hand? Okay, fully supported by the board, Catherine. Thank you very much for your hard work. Go and make it happen. Thank you. So we're then on to our quality reports, the first of which is the Safe Nursing and Midwifery Staffing Report. Daljit. Daljit, if you're talking, I can't see you or hear you.
Apologies. I think I lent on my earphones. Yeah, so really to take this report as read, I just want to start by referring to the Chief Executive's report on some of the staffing challenges that we've experienced, and certainly within George Eliot over June it has been quite challenging as a result of staff isolating due to being in contact with COVID, but also additional areas that we've got open, and also supporting the Accelerator programme. So in combination, that's been really challenging for us, and maintaining nurse to bed ratios has been quite difficult at times. We've got a similar pattern throughout July, so in next month's report you will see something similar. We've done as much as we can to try and fill those gaps through bank and agency. We've lifted some of the golden keys, but actually even doing that, the agency and bank are also finding it difficult to provide us with those staff for the similar reasons as described. So you'll see therefore that in June we've had 10 datexes raised as a result of reduced staffing, and 5 of those were red shifts. the assurance that I can provide to the board is that we continue to have that high and very detailed oversight on our staffing levels. We review them 3 times a day and extra meetings as well if required, but that has required that we've needed to redeploy staff to different areas in order to mitigate those risks and to ensure that we've got governance in place to monitor our staffing levels and support patient safety. The knock-on impact on that is obviously for staff who are moving quite often now onto different wards, and having had a difficult year already, this has an impact on staff morale. So board will be aware that I have sent a letter of thanks and support on behalf of the Trust Board to all our staff for their tremendous work and ensuring that we keep our ward safe as possible at all times. As a part of that, very mindful that many of these nurses we're moving are still in their preceptorship programme, and would highlight that it's not ideal to move our nurses that are in the preceptorship programme. We have been required to do that. So I'm currently working with the education team to see what further support we can offer these nurses, because obviously that's quite key to our retention. And in terms of vacancies, there's been a slight increase in registered nurse and registered midwifery and healthcare support workers vacancies in the month, but mindful also to point out to the board that we have recruited to just over 49 whole-time equivalent registered nurses and midwives, and over 18 whole-time equivalent healthcare support workers who will be starting with us over the next few months. For the rest of the year, we've got a further 5 registered nurse recruitment days planned, and 3 for healthcare support workers. So we continue to be very focused on strengthening our staffing levels, as highlighted by Stephen in his paper, to also support our winter planning as well. Is going to be important that we keep focused on this. Happy to take any questions.
Thank you very much, Daljit. Questions or perspectives to Daljit? Glynis.
Thank you, Daljit. I know it's a real challenge at the moment covering all of the wards and keeping patients safe. And I did just want to commend you, because I know that the care hours per patient, despite the fall in number of staff, has continued to remain high. And just not to answer now, but think about, is there something there that we can learn, that with reduced staffing we still manage to deliver those number of patient care hours? And my question is to do with the chart about ESR vacancies and budgeted establishment, because there is quite a difference between the two. And at what point are we going to probably reconcile it or get one set of data? Because I do find it a challenge to interpret 2 sets of data that are different.
Yeah, so I think that's been a task over a number of years, really, a number of months, that we've been trying to align the HR data with the finance data. And, that's work continues. And I think as we've had new areas open, we've tried to get that aligned. I think it's probably going to take a further few months to get that right. We continue to have a meeting regularly, which enables us to look at the data across the 3 areas and just see where those issues are. Obviously, the efforts into COVID over the last year have slightly distracted us from doing that, but we are really mindful of that, which is the reason for reporting it, so that we can see that we are aware of the issue and we are trying to do something about it.
But your narrative is helpful in explaining what you're doing.
Yeah,
so thank you.
Thank you, Glynis. And finally, Rebecca.
Thanks, Russell. Thanks, Daljit. A really open and honest report. From a health and wellbeing guardian perspective, what assurance are you taking in regards to safeguarding our staff from burnout, etc., and these other challenges, please?
Yeah, so I think one of the big things we're encouraging at the moment is for staff to take their annual leave, which I think has probably added to some of the staffing shortfalls that we're seeing. And part of that, all our regular wellbeing activities that we've talked about before, which I know Gertie's talked about, they continue, and we continue to support staff. And it's really encouraging people to speak. So, we're continuing to go out onto the ward areas now that we're, have got not so many COVID cases in the hospital, to ensure that the corporate nurses are out and constantly communicating with the ward staff. We speak to them on the daily meetings. We have regular meetings with them to see how staff are doing, and just ensuring that we continue to reinforce what is available for staff. I think sometimes staff don't realise just how tired and exhausted they're feeling, and actually getting them to recognise that and to access the support is the area of focus, because sometimes they feel they just don't need it. I think what really helps staff, and where I guess the challenge for us is now, is that if they're working with their teams, they get that support from their team members. But when we're moving them around constantly, they're missing that. And that is an issue that I've picked up that we're talking to our staff about.
Thank you.
Thank you, Rebecca. And your point on staff wellbeing, equally, I'd say to executive director colleagues, you need to take your own holidays. You've had a phenomenally tough year, so make sure you have time to recharge your batteries. Although, as I jokingly said to Glenn when Glenn had to self-isolate, there's a wonderful video which says you have, talking to a father, you have an option. Option A is to stay isolated with your wife and children, or option B. And he immediately says option B. So I am aware, even from my own experience, that sometimes going on holiday with the family isn't the most relaxing of things, but you do need to make sure you look after yourselves. And again, on behalf of the board, I just want to reiterate our thanks to everyone on the front line for the phenomenal sacrifices they've all made. Colleagues, happy to move on to the CQC progress and preparedness update. Back with you, Daljit.
Okay, thank you very much, Chair. So I'll take the report as read again. We continue to make progress on the 5 remaining actions, which are amber. One is must do. The board will note that a couple of those actions are translated into longer term improvement projects as a part of the patient safety work. So we'll start to see some movement on those. In terms of the report, I just want to highlight the peer review that was undertaken in ED. Again, just referring to our discussion at the board workshop this morning, where I think you saw firsthand the tremendous improvements that have been made. I think of note, particularly from the reviews, was the cultural shift within ED. Reviewers felt very welcomed, and they actually noted a very supportive, engaging team that that are working together on ideas to make improvements, and so eager to share their ideas and what they've done. And the other element I just wanted to point out in the report is that our quality governance team meetings are up and running now, proving to be very helpful in sharing learning and also focusing on improvement themes. And you'll note we had as a result of some of the themes that have come in out of the patient experience surveys and the complaints in PALS, we did a big improvement theme around discharge, which you will have noted in the report. So happy to take any questions.
Thank you, Daljit. Questions or perspectives to Daljit, Glenn?
Just a plea really from me, if the CQC are watching this meeting, could you please come back and inspect our emergency department?
Absolutely. It's something we're incredibly proud of. And Glynis?
Just to say, Chair, we have received this Quality Assurance Committee and had a robust discussion around it. And I think this is just a reflection of some of the things we've talked about earlier today, the real focus on improvement culture. And I can give assurance that this is really a positive piece of work. So well done to everybody.
Thank you, Glynis. Colleagues, happy to move on? So we're then on to the Mortality and Learning from Deaths Q1 report. Catherine, what would you like to pull out?
Well, I'd like to pull out the good news, Russell, that our shimmy is now 100 in this reporting period, which is bang on the expected number of deaths, the observed versus the expected. Our HSMR in this reporting period, and they haven't reported for 2 months because of technical details at NHS Digital, is still outside the expected range at 110, but has fallen very significantly this year. And if you look at figure 3 in the paper, we used to be on the left-hand side of that graph, and we are now tantalisingly close to the expected range, in the middle of the pack now. The pre-published data, which I get to see before it gets into the public domain, looks very encouraging for the next reporting period. So I'm expecting us to be in the expected domain when that's published next. Really pleasing to see the high level of reviews done by medical examiners, officers, the medical examiners. 95% of deaths in this quarter are reviewed by a medical examiner, which is another way of checking for any problems and learning from deaths. We do have to extend that out from April next year across all community deaths. That's going to be pretty challenging for us. So at the moment, we're trying to work out how we are going to achieve that. But we're looking to appoint a medical examiner's officer to support with that work. There was one COVID-related death in that quarter, so that's very different from the first quarter of last year. And that's really all I'd like to pull out of that report, Russell.
Thank you very much, Catherine. Questions or perspectives to Catherine? Okie dokie, super. So we'll move on then to the trust-wide incidents report. Again, Catherine, with you.
Yeah, so we're starting to see an increase in the number of incidents reported in this quarter, which is great news, because what we're trying to do is have a really strong incident reporting culture, but see a reduction in the number of moderate, severe harms or deaths related to healthcare. We have also seen an improvement in the number of open incidents. So the teams have been working really hard. I really want to thank the Directorate teams, particularly the Directorate Governance Coordinators, who are working really hard to turn these incidents around, get the learning out of them in a timely fashion. And they have made huge strides on that. So a very big reduction there. There were only 3 serious incidents reported externally in the quarter. And in terms of duty of candour, we're about to re-audit that again, but seeing really, again, I think a strengthening of the processes around duty of candour, so that when things do go wrong for patients in our care, we apologise for that and follow our obligations, but we want to be open and transparent with the people that we are looking after, and that's really important for us that we get that right.
Absolutely. Thank you, Catherine. Questions or perspectives to Catherine? Glynis.
Again, just to say, Chair, this is a report that regularly comes to quality, and I can just let board know that we've seen a real strengthening of incident management and learning from them and embedding them. So again, it's a really positive piece of work that should give us confidence in patient safety in the organisation.
Thank you very much, Glynis. Colleagues, happy to move on? So then over to the Ockenden report, progress, or the plan assurance report. Back with you, Dalgid. Thank you.
Thank you very much. So this report provides an overview on how governance has been strengthened in the maternity services to give the assurance of the ongoing improvements being made. I do want to highlight that we haven't included a detailed update on the actual action plan itself and the rating. The reason for that is we submitted our evidence to NHSE on the 30th of June. We're waiting for that response back from them, and for this reason we will bring back the updated position once we've received that. What I want to try and do is have a consistency in how we're measuring our progress rather than trying to rate it ourselves as well. So I will bring that back as soon as we've got it. However, what you can see from the report is that the actions continue on the number of areas that we need to make progress on, but also again to highlight to the board that there's quite a few actions that need support either from the system or nationally to move those on, and those discussions are happening. The plan's being monitored at the directorate meetings and also through the system, through the local maternity and neonatal system board, also known as the LMNS. And finally, just to highlight to board that we were successful in receiving funding of just over £225,000 from the NHSE funding, which we bidded for. That isn't all of the money that we had put in for. However, this funding should support, particularly in terms of getting and facilitating the multidisciplinary training, which is one of the key areas within the Ockenden report. So happy to take any questions.
Thank you very much. And that 250,000 award is pretty good in the context of what some other trusts have received. Questions or perspectives to Daljit? Julie?
Thanks very much for this, Daljit, and it's good to see this report on an ongoing basis, which I know is discussed at QAC. I guess we continue to see continuous press around maternity, which puts a lot of stress on our staff as well. So just to acknowledge that and to ask how they are feeling is the first thing. Second thing, though, is how, Ockenden took a long time to come out. And I suppose it's about how we as a trust are actually reflecting on learning, not necessarily from things in the press, but from things that you learn from your colleagues.
Yeah, no, absolutely. So just I think to respond to the first question, I think that the focus on maternity, and you can see it in all maternity units, and the impact for staff is quite, considerable, particularly on the top of coping with COVID and the ongoing pressures of that as well. So I think that the well-being of our maternity staff is particularly key. So I myself are meeting with them regularly. I meet with the matrons every couple of weeks, and just to give them that support. We have put additional support into our maternity unit with a very experienced director of nursing who's retired and who's supporting them as well. So we're just making sure that they know they've got our support and that we're here to help them get that right. And what we're also trying to do, and I guess it links into the second point, but again, it's supporting them, is aligning our corporate governance team with their governance team. So they've got that support, and we've got that more openness in terms of the quality assurance around some of the data they're collecting, and also been able to ask some of those questions which an external governance team might ask in a different way. So we have talked about actually learning from what's happening around maternity. And one of the pieces of work I've asked Kay to do, who's supporting us in maternity, is to review all recent reports, including reports that the CQC have published recently in maternity, and we're hoping very soon to have a workshop with our Quality Assurance Committee and other colleagues to go through some of that and to cross-check that we are cited on all of those issues as a part of our own improvement plan, which is not just about Ockenden, but everything that we're learning. And certainly I myself, I'm in contact with my chief nurse colleagues, both on a WhatsApp group, and we all meet on a Monday, on a Friday, on a regular opportunity for us to have those discussions about what we're all learning and sharing it with each other.
Thank you, Daljit. Thank you, Julia. And then finally, Catherine.
Yeah, I just would like to acknowledge what Julie said and support what Daljit in her response. It is really difficult, I think, for our maternity teams when things do go wrong or if there are problems. Daljit and I and Simone and the other people involved are trying really hard to make sure that they really genuinely understand that people will not get blamed for raising concerns. We want to support them when things go wrong. We need support. We need to learn from it. We need to support families, and we need to support our staff. And that is our commitment to the public, that we will always learn if something goes wrong, but we will not seek to victimise people or blame people. And actually, I think we are very lucky here with the culture that we have among the board, amongst our teams, that it is open and honest, and that is a culture that's seeking to continually improve. So yeah, we do need to support our staff and encourage them to speak openly, but they do, and they are a testament to that.
And I think we've had some really good examples recently where the maternity team staff have actually raised issues that they're concerned about and had open discussions about them both in QAC and indeed we talked about on that board in relation to the CNST submission as well.
Well said, Catherine. Well said, Daljit. Thank you. Keep us brief, Daljit, I know you will. Yeah. So we'll then move on to the Integrated Performance Report. David, key things to pull out, please.
Yeah, thanks, Chairman. So first thing to say is we continue to work to improve both the report and the process of performance management that we have in place across the organisation. I think it's worth just reporting that at the board workshop this morning, we spent some time reviewing that approach, having had our FPE arrangements in place for the last 6 months, and I think we're quite pleased as a board with the way that things are going. We've got some things that we can do to make it even better, but we've made a pretty good fist of getting that into shape. So we'll continue to use the kind of format that we've seen presented for the last 6 months and here today. So in terms of drawing out some of the headlines following our FPE meetings, joined by members of the non-executive director team, I won't cover off ground that's already been covered in other bits of the meeting. So we'll go straight to clinical quality indicators. We continue to focus quite a lot on falls. There were 17 inpatient falls during this reporting period, and it's good to see some quite creative and innovative actions beginning to develop to address that, including a revised review process, seat sensors, and the role of the falls coordinator beginning to develop and to become much more integrated to our approach to managing falls across the organisation. From an infection prevention and control perspective, a generally good performance. 2 C.diff cases though to report this month, so that gives us 6 year to date against a threshold of 14. So need to keep an eye on that, and I know that happens through our infection prevention and control committee and into QAC. Pressure area care continues to be an area of focus for us, and you can see as part of our development of this report, for the first time we're reporting FFT response rates and outcomes, and pretty good response rates above the nationally set thresholds, and the majority of patients reporting a good or very good experience of the services that they use. So that's good to see and very positive. From an operational performance perspective, A&E attendances remain very high, as they do consistently across the country. Our performance continues to be strong despite that position. We're reporting around about 92% performance against the 95% threshold, but definitely up there in the top quartile. And in fact, this morning our A&E team were telling us that we were number 7 nationally this week in terms of performance. So that's really strong and really positive, and good result for the whole hospital, not just for the A&E department. From a planned care perspective, there's been a reduction in the number of patients waiting more than 18 weeks for their treatment, which is good to see. Quite a big number. That's reduced by 431. We've seen a continued reduction in the number of patients waiting longer than 52 weeks for their treatments, and that reflects the work that we've been doing to put additional capacity on the deck against the accelerator programme. Hasn't made a massive impact on RTT performance against the top line measure, but we've known that wouldn't happen for some time to come, and that's what we're seeing playing out. Diagnostic performance remains strong, although we're slightly below the 99% threshold, 0.19%. That's largely due to some challenges around cystoscopy capacity, actions in place to address that, and would expect to be back up there next month. The national performance figures weren't available when we went to press on this, but we would expect still to be near the top of the performance table associated with that. And cancer, so the top line performance around 62 days remains pretty consistent, is below the standard. Our internal figures improved. We will make the reporting of that a little bit clearer going forward, but we continue to be focused on case managing every patient who's on a cancer pathway, and we have a tiny number of patients who are waiting over 104 days for their treatment, and that number stands at 4, and as I say, those patients are being actively case managed. Some improvement in stroke measures, and I think it's fair to say both cancer and stroke, as an executive team, just concerned that performance is a little bit erratic, so need to make sure that the improvements that we put in place to address those are sustainable going forward, and that we properly stabilise. Too much movement in the numbers for us to be able to draw improvement conclusions going forward. So we'll keep you posted on that. And then finally, in the workforce and people theme, vacancy rates remain low. Band 5 nursing continues to be our key area of challenge, and both our professional leadership teams and the HR team are very focused on that in terms of process of getting people into post. Some good work to recruit into some hard to recruit medical specialty posts and referenced in the report are anaesthetics, radiology and paediatrics. And statutory and mandatory training, we continue to deliver above the 85% threshold, with a couple of targeted areas of support in medical and dental and estate and ancillary staff to make sure that those distinct groups get their performance above that 85% threshold. So that's a canter through this month's IPR, and I'll stop there. If anyone's got any questions, I or one of my colleagues will do our best to answer.
No, great, David. And votes will be taken at the end of the board meeting as to whether we like David's goatee look or whether we think he should have a shave after the weekend. So won't be using the digital hands on that, David. Really good development of the integrated performance dashboard and report. Questions or perspectives to David? The A&D performance is absolutely stellar.
Yeah,
and we celebrated it this morning, but we'll celebrate it in public again now. Absolutely stellar, and everyone involved in that should be delighted. And a great example, to be honest, of the benefits of the collaborative working across the foundation group for members of the public, because there was an initial sort of incubation help with some colleagues from Swift, but it's been really since Nhs has arrived that things have really started to motor, which is fantastic. He is a star. Nhs, if you're watching by the wonders of YouTube or however we share this video, you are a star in the board's eyes. And Glenn, and then we'll move on.
Yeah, just briefly picking on what David said there. I mean, as well as the A&E performance, there's a really good rounded set of performance indicators here on quality as well as activity and safety. So well done to everyone, because these are challenging times, but it's, most other trusts are going in the wrong direction, and our numbers are going in the right direction, which is great.
Yeah, no, absolutely, Glenn. Okie dokie, so we'll move on then to the finance report. Hack, as I said, you're driving through fog at the moment, but just brief us as you want.
Thank you. I'll just pull out some of the key points. So we've got a surplus of just over £1 million at the end of the first quarter. That's £300,000 better than we planned. That's largely due to vacancies. I'm expecting the surplus to unwind in the second quarter as we make further progress on recovering activity levels, and so as we increase planned care activity levels, we will see that position unwind. We were originally forecasting a break-even position, but as you can see from the report, there's been a national change to the threshold that's being applied to the Elective Recovery Fund from the 1st of July. That means we will get £1.3 million less income than we originally were planning on. We expect to be able to mitigate some of that, but not all of that. So the risk is here that we end up with a deficit at the end of H1. There's a further risk as well, because the Elective Recovery Fund is earned at system level, not organisational level. So if the system doesn't get above the 95% threshold, and there's a real risk of that happening in July, we will fall short of our planned level of Elective Recovery Fund income. On a more positive note, in terms of our CPIP programme, we're doing really well and expect to be able to deliver our target. There's enough in the pipeline to be able to do that, and we review that monthly with the directorates at our finance and performance executive meetings. The directors have also been planning ahead for the second half of the year, and they've started developing CPIP plans for the second half of the year and making good progress on that as well. And another key focus going into H2 is reducing our COVID spend. So we're doing a line-by-line review on our COVID expenditure as well. And the final point I was going to flag is that there's a renewed national focus on paying suppliers as quickly as possible. So the target they're going to focus on over the next few months is going to be making 95% of our payments within 30 days. And I'm pleased to report that we're there or thereabouts against that target. So in summary, expenditure is well controlled. We're making good progress in delivering the savings targets and reviewing our COVID spend, but there is a risk of a deficit at the end of H1 due to the national mandated changes to the Elective Recovery Fund threshold, as well as a system risk around that. I'll take any questions.
Thank you, Hack. Any questions to Hack? Okie dokie. I think it's worth putting on record, and Glenn, if you disagree, please say so. I do worry about the way the current financing regime doesn't appear to incentivise those organisations who are really trying to drive into elective work. And so I think it really is the area that needs to be watched, that under the old payment by results scheme, whilst it had its problems, there was a clear incentive to get things done. And as the financial regime develops, it's important to ensure there is still some incentivisation for those organisations who really put their shoulder to the door, so to speak, to make stuff happen. Glenn?
Yeah, completely agree. In fact, you could almost argue there's a disincentive now with the raising of the threshold to 95%. There is a risk that a lot of organisations will decide it's out of reach and will therefore stop doing additional work to save money. So you could end up with organisations in a better financial position by not doing their elective work than those who try and do it. And that has to be wrong. It's an issue I've raised nationally, and I hope they do reconsider.
Well, we live in hope that wisdom sees through, so to speak. We'll move on then to the governance issues. Thank you, Hack, for your hard work. A summary of ratified policies. David, anything you particularly like to pull out?
No, I'll take the paper as read. 2 policies approved. Happy to answer any questions.
Okay, any questions to David on the summary of ratified policies? Okay, great, thank you. Then we'll move on to the Controlled Drugs Annual Report. Catherine?
Okay, well, I'm going to provide partial assurance for the Controlled Drugs Annual Report. That's really because of the pandemic. We were not able to complete the number of audits that we would usually undertake for the management of controlled drugs. On a positive note, we are compliant with all of the things that we are meant to be compliant in terms of having a controlled drugs accountable officer, in terms of our compliance with our submissions to the local intelligence network. And it's also pleasing to note that we have had no serious incidents related to the management of controlled drugs. But I think to be able to give you significant assurance, what we need to see is those audits restarting. They have restarted in this quarter. And that will then give us the full assurance that we are managing our controlled drugs appropriately, but the rest of the report can be taken as read.
Thank you, Catherine. Questions or perspectives to Catherine? Okie dokie, then we'll move on to the Medical Appraisal and Revalidation Annual Report. Catherine?
Glynis has got a hand up.
I apologise. Glynis?
Just to say, we did receive this report, Chair, at QAC, and as Catherine said, one of the things we're doing is just bringing the report back on a quarterly basis as an update, so that will strengthen the assurance, but we have no real concerns about it.
Great, thank you. Colleagues, happy to move on to Medical Appraisal and Revalidation Annual Report. Back with you, Catherine.
Okay, so I think this is another good news story. This is usually me reporting on my own performance, which always feels a bit odd. This time we have had an audit done by the Trust auditors, which shows that we were compliant with 31 out of, or we could provide evidence for 31 out of the 36 standards in the NHS England document, a framework of quality assurance for responsible officers and revalidation. Despite a really tricky year for doctors undergoing appraisals for the whole of the organisation, we have managed to maintain a really high appraisal rate amongst our medical staff. It's not often that the doctors can say that they're the best in class, but for appraisals performance, we are the best in class for doctors. And I think this was really important that we made appraisal part of the well-being for our colleagues rather than seeing it as an additional burdensome thing that people needed to do. We wanted to support our colleagues, check in with them, make sure they were all right, and continue through appraisal to drive forward the importance of quality improvement. What are you doing to improve the quality of care for our patients? So there's a couple of things that are drawn in the audit. We had planned to hold a peer-to-peer review of appraisal and revalidation with Wye Valley. That was scheduled for March 2020, so that fell by the wayside of COVID, but we will reschedule that before the end of this financial year. Otherwise, there were some minor changes that needed to be done to the policy to strengthen that. And in order to provide evidence of the refresher training that our colleagues who undertake appraisals do, that's a really valid point, and we have rescheduled another session so that we can make sure that we can evidence the training that our appraisers have to undertake the appraisals. But I think really great work by appraisers, by doctors in this difficult year.
Thank you, Catherine. Any questions or perspectives to Catherine? Okay, apologies. I'm just needing to close the window. Bear with me. Streamer stops ball waiting. Apologies.
Doesn't sound like Abaddon to me, that, Chairman.
I know, thank you. Moving on then to the subcommittee chairs update, the first of which is QAC from the 28th of June, the report, and then the 26th of July verbal update. Glynis, over to you.
Okay, thank you very much, Chair. It was a very positive and assuring meeting on the whole. I just want to highlight a couple of reports that board may not be cited on. We received the annual report on the Trust Library Service, and it clearly demonstrated the quality of the service that we've got in place here and the considerable innovation that's taken place during COVID. And we are really fortunate to have such an excellent service. They're just currently benchmarking against the national framework, and we'll have the formal results of that early next year, which we will bring back to board. We also received a report on the quality of medical education at the Trust, and again, it was a lot of strong evidence showing how good the service is. That was the GMC training survey results, the successful education inspection visits, and most importantly, an increase in our training places. So again, a real service we should be proud of. Catherine and all the team have done an excellent job there. We commended the innovation and the hard work that took place to offer, continue to offer high quality placements during very challenging times of COVID. The other report we had, you may recall, we had an external inspection of nursing documentation audit done in 2019. We can report now that all the actions against that is complete. The compliance is currently being monitored through the nursing care quality indicators rather than formal audit, given the pressure on time. And generally, the compliance levels with that were really good. So again, that gave us a good degree of assurance that the work that's taken place since the audit has significantly improved the documentation. Then I think the only other thing to say is Darjit's talked about Ockenden, and we received a monthly dashboard from maternity services. There's been a lot of work that's taken place to improve the reporting and to strengthen the governance, and that was evident at the last meeting. I think the only area that we just wanted to highlight and get a little further assurance on was out-of-date policies. A lot of work's gone into it, and we're fairly confident that those will all be completed against probably ahead of the trajectory in September, but we have just asked for some further assurance regarding any policies that are past their date. Happy to take any questions.
That's great, Glynis. Thank you. Very assuring. Any questions or perspectives from colleagues? Okay, thank you, Glynis, and everyone involved in QAC. And so we move on then to the Audit Committee of the 27th of July. Julie, anything you particularly like to pull out?
Yeah, just a couple of things really, Chair. So I'll assume the report's read. We did take the opportunity at this meeting to review the effectiveness of the committee, but also the quality of the reports. And I'm really pleased to say about how we acknowledged the good quality of reporting, which were well presented, and it allowed us to have very open and focused discussion at the meeting. I've highlighted the areas for attention in the report, but I would want to just mention the report on pharmacy stock losses. This matter has been escalated to board before, and it's been also escalated to Trust Management Board to ensure that there's a focus on these losses and that there is the engagement of clinicians, because without that, pharmacy can't control these losses. The report sets out the reasons, but we have asked, as have TMB, for more detail, and I've set out the actions that are being taken. And just to note, there will be a further lessons learnt at the next meeting of audit around the business cases for a septic unit and the outpatient transfer, and there will be some wider learning, not just about those specifics.
That's great, thank you, Julie. It's always about the learning. Any questions or perspectives to Julie? Julie, whilst I'm with you, anything you wanted to add to the minutes from the 25th of May or the Extraordinary Audit Committee of the 7th of June?
No.
Thank you. Thank you, everyone involved in Audit Committee. Any other business from members of the board? Please raise a digital hand if you have any other business. Okay, I'm not aware of any questions from members of the public, but if any members of the public want to ask a question, do you want to raise a digital hand now, please? David Carr.
Thank you, Chair. A statement first, if I may, and then I do have a question. At the moment, Chair, I'm feeling proud, I'm feeling excited, and I'm feeling supportive. I'm proud of everyone in the ED department on the incredible achievements of service to the public in spite of all the challenges of bad behaviour by members of the public. And that's where I support Glenn in his statement that we should have zero tolerance to this sort of behaviour to the staff. They're not paid enormous salaries and they don't deserve to be abused in any way, shape or form. The other thing that I'm excited about is to hear all the positive noise or reports on the hub, the diagnostic hub for Warwickshire North. And I just wonder, one question, Chair, is there any timeline when the phase 1 will be completed and operational? And the same question really on the new theatres that you're having built. Is there any idea when elective patients will start getting treatment in the new theatres? Thank you.
Thank you, David. So in terms of the Community Diagnostic Hub, first, Catherine, with you.
So the answer to that question is, David, assuming we get the money that we have been nominally allocated, that building work will complete at the end of March 2022. So not long to wait for phase 1 to be operational, all going well.
Thank you, Catherine. And in terms of the theatres, Stephen?
Yeah, we'd expect it to be the end of September, beginning of October. The theatres are actually handed over to us at the beginning of September.
Okay, great, thank you. And any other questions from members of the public? Well, thank you to David and others for joining us today. Our next meeting is on the 7th of September at 2 p.m. So look forward to seeing you then. In the meanwhile, colleagues will have a 10-minute break and get together for the confidential board at 3:45. See you in a little while. Thank you.
Thank you, Chair.